So our panel consists of Dr. Singhal, who's our chief of our lymphatic surgery, Kevin Donahoe, who is the imaging, Leo Tsai, also imaging, Katrina Fritz, lymphedema therapist, and Betsy Rose, nurse practitioner from our lymphatic medicine clinic. So Betsy's going to present the patient, and then we'll hear from the rest of the team members. I have a microphone, so as we have questions, I can roam around the audience and you can ask your questions. Did you want to add something, Dhruv?
Yeah, I just want to, give the context here. So this is a conference we have once a week in patients that have already been seen by Betsy and or Brett. They've already been seen by Katrina or the lymphatic treatment team. They've already been imaged, and their imaging has already been reviewed by Leo or Katya and Kevin. And now we're coming together just to have a discussion on, are they a surgical candidate, are they not, or where do we recommend their treatment to go?
And there are usually a lot more people than just the 5 of us.
Oh, right, and there's usually about 13 or 15 of us when we're doing this, so it's usually many representatives from each of the division present, and usually there can be healthy discussions had during these meetings. So I just want to give context about what you're about to see.
And there may be a healthy discussion after you present from the audience members, and that's why I'll be roaming with the microphone. So, we'll take some questions after the team presents.
Okay. So Ms. Jones is a 60-year-old female that presented to our clinic with predominantly right lower extremity edema, but she also had some mild right upper extremity edema. She said she first noted that the swelling in her her right lower extremity occurred in April of 2022 after she took a 10-hour flight. She did not have any other precipitating injury or trauma that she could associate with that. So she had undergone a venous reflex study and then also had a repeat CT abdomen of her pelvis. No evidence of metastatic disease on her CT. However, there was a notation that her right common iliac vein had some narrowing, but not really clinically significant at the time. So of note, she'd also been diagnosed with breast cancer in 2016, had a bilateral mastectomy, treated with chemo, and then subsequently did have metastases to her axillary nodes, and she had to undergo an axillary lymph node dissection. She then had neoadjuvant radiation, and then that's when she started to kind of notice that she had some mild swelling in her right arm. She wasn't really so much bothered by the arm, it was more so that the leg was her more concerning extremity. So in regards to her leg, she was having problems with fitting into clothing, had pain, tightness, heaviness, swelling, which only slightly improved with elevation. And her main goals were really to try to get into clothing that fit better. She did not want to have any infections, and she really wanted just overall improvement of symptoms. So going back to her leg, she again said nothing in her history that she could recall to the inguinal area, pelvic area that would have caused the swelling. She did live in Kenya for about a year, but that was in the 1990s, so well before she presented to our clinic. History of hypothyroidism and osteopenia. In terms of her breast cancer treatment, she was treated systemically. They were concerned about metastases, but really no problems with that overall. So on her initial exam, she did have mild to moderate increased girth of her right lower extremity with 2 to 3 millimeters of pitting edema, mostly in the distal right pretibial region with a negative stemmer sign bilaterally. She also had moderate increased girth of the right arm, but only 1 millimeter of pitting. And then on follow-up about 4 months later, she had increased girth of the right lower extremity with more significant pitting and now a positive stemmer sign. So we then went ahead and did a nuclear lymphoscintigram, which we're going to go over with Kevin. And then based on the findings, we had said to her, look, it looks like you have some delay of the lymphatics. Why don't we try to get you into some conservative measurements for the leg? So we then had her see somebody more local to her because she didn't live near Beth Israel. So in the meantime, she had started conservative therapy, but we decided that even though she had lived in Kenya so long ago, we would go ahead and evaluate things for our filariasis in terms of infectious disease. So she did see our infectious disease folks. Her filariasis testing came back negative. Told her, go ahead, see how conservative therapy works. Did a course of decongestive therapy with her local therapist, but then came back to us and said, look, I've really had no improvement. And then at that time, just because we've got such a great relationship with our local therapist, that therapist reached out to us and said, I've been rapping and haven't really seen much of an improvement and not really quite sure why. So then that kind of prompted us to go back to that outside imaging that she had of her abdomen and pelvis. It had been done at other facilities, so we obtained the images, and with the help of Leo, who will also go over those images, we had seen that maybe there was more significant iliac vein compression. So then at that point, we referred her for a venogram, and then she underwent a stenting of that vein, and then came back to us and had started to see some improvement after the stent. And then in most recent visit, she had had a decrease in her volume difference in the right lower extremity. It did remain slightly larger, but there was a marked improvement in her pitting edema and how she was feeling in terms of symptoms.
So for the therapy team, we saw her twice and did some measurements. So at first, her BMI was 25.3, and at the most recent visit, it was 25.5, so stable. We did a percent difference in LDEX on her upper extremity, even though that wasn't really impacting her a whole lot. So her percent difference in her upper extremity was 18.9%, and her LDEX in the right arm was 20.9. And then at the initial visit, her lower extremity difference was 29.1%, and at the most recent visit, it was 27%. So only a 2% difference for us. On her initial visit, her LDEX was 38.2, and then on the most recent visit, it was 40.5. So also not too much different. At the most recent visit, she was in 84 hours of compression. She was in ready-to-wear knee highs and then a tuba grip for her thigh management. She was doing CDT with the local therapist, but felt like she was plateauing, so she stopped. And then her overall quality of life score is a 4 out of 10, and then her limb QOL for her upper extremity was 76, and for her lower extremity it was 92. So basically how we left it was she needed to go back to CDT and do a little bit more wrapping, and then get her into a flat neck garment because she wasn't fully there yet because she still had some pitting edema.
Okay, so I'm going to show you some MR images first. So the images on your left over here, these are actually fluid, what we call fluid sensitive sequences. So things that are bright on that image correspond to edema. And the images on the right are fat only images. So things that are bright on those images correspond to fat. So I'll just start with the upper left image there. That's the pelvis, and then the mid over here, those are the thighs, and then those are the calves. And you can see, again, this is the fluid sensitive sequence. You can see there's pretty extensive fluid overlying the anterior subcutaneous soft tissues along the pelvis and also along the right side, a little bit on the left as well. When you get to the thighs, it's pretty obvious that there's a lot more edema on the right side than on the left. And in the calves, that difference is even more. There's really, this is what normal would look like. And there's all this bright signal along the subcutaneous fat. On the images on the right, you can also see that there's actually a little bit more fat if you look at the level of the thighs on the right side, and both in the thighs as well as in the calves. So those are the MR findings.
How would you rate that fat?
So I'd say that was about moderate fat hypertrophy. So, oh, and one more thing. This is an image actually at the level sort of blown up here, showing that there is this sort of this filling defect or compression of the right iliac vein, which is what was mentioned earlier.
Okay, so this is the scintigraphy, and she's kind of interesting, although all our patients are interesting. One of the things I've noticed is that you just see this variety of patterns of scintigraphic images, and it's hard to put them all together sometimes, but she's very interesting in that at 30 minutes, she has nice channels on both lower extremities all the way up until on the right, she's got this rim or this area of dermal backflow at the top of her thigh. We may see a little lymph node here, but we certainly see lymph nodes on the not so symptomatic side, on the left side, but channels all the way up. And then at 2 hours, she's just got this dermal backflow from the top of her thigh all the way down to her foot. And she does have a couple lymph nodes showing up there. And then on the other side, she has lymph nodes, but she also has popliteal nodes. And this is the reverse of that image. So the right side is over here and the left side is over here. There's a posterior view. And you can see popliteal nodes, which is kind of unusual for us because we're just injecting on the dorsum of the foot. And that's not a dermatome that usually drains to popliteal nodes. To get to the popliteal nodes, you usually have to inject laterally at the ankle or maybe a posterior at the calf.
And I think we picked this case because we wanted to show non-surgical management or our decision-making here, where, in this case, the lymphatic medicine team, along with Jeff Weinstein from IR, went ahead, placed a stent into the vein. They had an improvement, and then deferred the patient back to lymphatic therapy or the local therapist for treatment. And then we would see how she does. With a stent, sounds like she was doing better. And then we would reevaluate her probably 6 months to a year later and see where she's at. She does look like she has fat hypertrophy. I wouldn't expect that to reverse, but we want to make sure she's maximized from a venous standpoint before we would consider anything surgical on her for the right lower extremity. And that's just a quick, was there anything else you wanted to share, Kathy, in terms of why we picked the case or what we were trying to demonstrate?
No, you're exactly right. I just wanted to pick one case that was more lymphatic medicine, since we've been talking a lot about surgery. I don't know if our colleagues from Alert have anything to add, or are there any questions from anybody in the room?
Just asking about her arm. What was the outcome there?
Yeah, I actually don't remember this case.
She really didn't really pay mind to it. I think she was just more concerned. I think she associated the arm, well, I had breast cancer. It was kind of one of those things they expected me to have. But what was more puzzling to her that she really needed to know the etiology of why all of a sudden now is my lower extremity acting up, and it's strange. And a lot of the times too, as Dr. Carroll mentioned earlier, trying to treat that medical side, making sure we're not missing things. It's also interesting because in the time that I've seen some of these patients, sometimes we've seen them and they've already had an attempt at some sort of stenting because it was initially thought that that extremity was swollen because of some sort of venous compression. And, people were just in the vascular community that they were connected with was just trying to throw anything at them, not really realizing or putting 2 and 2 together that maybe it was lymphedema. So just one of those things. And then I think we also picked this case just to show how important staying in contact with our therapists, whether they're internal or external, and having that nice communication between the two groups. Really paying attention to the therapist when they say, hey, I'm really throwing the book at this patient and nothing's really happening. I'm not quite understanding why we're not getting the result that we're hoping for. So that was just a nice way of collaborating with those in the community and staying close with them.
So Emily saw this patient, but just from what I know of her and how she treats, I feel like she probably wanted to tackle what was more bothersome to her first. And then I think maybe once she was in a good garment and was feeling like that was managed better, she probably would then tackle the arm and probably work on that. But she probably just wanted to focus on one thing at a time, is what I would assume.
Yeah, but it's a good point. I mean, I think we said the volume difference on the arm was 18%, LDEX
Yeah.
40-something.
Yeah.
So you're right. That's right in the range where we would be treating both non-surgically and surgically. But it also speaks to how we are very patient-oriented. We often see things where we want to do things, but we always focus in, as I think you heard a couple of times, what is the patient here for? What is their main concern? And we want to make sure we address that. And it sounds like it really was the lower extremity in this case.
So I'm sorry, I'm trying to wrap my head around it. So you've gotten her under control venous-wise, but now after waiting a certain amount of time, are you then going address the issues with the lymphatics because not having any of the lymph nodes on that side light up and having that dermal backflow?
100%. It matters what she comes back in with. Once, I think, Betsy, the way we had left it is she was doing better after stent placement with improvement of some of her objective measures in the lower extremity. So now if she maintained that or got better over the next 6 months to a year, when she came back in, we just have to readdress and say, okay, what are your goals now? If she truly was happy and she didn't have concerns, I would see no reason to operate on her. But if she, again, is bothered by size, she's got moderate fat hypertrophy, even though she has no lymph nodes, we would perform a debulking on her. That would be our algorithm for this lower extremity, is to debulk her, stabilize her, and then even consider a transplant or bypass in 1 or 2 years based on whether or not her ICD demonstrates channels, and the high-frequency ultrasound also demonstrates channels in a target vein.
Yeah, and if you take the hydrostatic pressure out of that leg, her lymph might start flowing a little better, and we might see nodes show up. So that's one of the values we found with serial imaging studies.
But that fat's probably not going away.
That's not going
But again, we don't see a need to operate unless the patient tells us that it's one of their goals.
I heard you say that was referred back to the lymphedema therapist out in the community, so she's going to be followed for a period of time, and then I think it sounds like Emily's going to follow up with her.
Yeah, I
So
think
as far as
so,
the
yeah.
therapy standpoint, conservative management, she's still kind of in the pipeline, even though she may not follow up in the clinic for 6 to 12 months.
And I'm just really glad you picked this kind of case because, we have straightforward cases. Breast cancer-related lymphedema, 3 years out, moderate fat hypertrophy, and I mean, we go through that case in about 2 seconds. We're going to debulk her, wait a year or two, and then go ahead with a transplant or bypass. These are the kind of cases that bog us down in the morning, where we're really going through methodically, okay, are we making sure we're not missing anything, leaning on lymphatic medicine to give their input on reflux and whatnot. So this really demonstrates kind of like the more complicated cases that we would see, which honestly are probably going to be reviewed multiple times over a few years.
Any other questions before we move on to the next case? I don't know who has the slide advancer.
Okay, so I don't have all of the exact dates of all of her surgery, but this patient, Jane Doe, had lower extremity lymphedema. I don't know what her cause was initially. Do you know? Some gynec cancer. Yeah. And so she had a debulking surgery in 2017. I believe. And then she had a lymph node transplant in 2019. So today we'll be talking about, we discussed her in December of 2022. So now she's 3 years post-op from her lymph node transplant. So her BMI is 23.7. Her percent difference is 6%. Her LDEX is 26.7. She's in 168 hours of compression in a class 3 thigh high and then a class 1 toe cap. Her overall quality of life score is an 8 out of 10 and her limb QL is a 32.
You don't have any of her pre-op values?
I do.
Okay,
Yeah.
So let's just compare
Sure.
pre-op to where we're at.
So her pre-op of debulking, her BMI was 27.1. Her percent difference was 23%. She had an LDEX of 56.1. She was in 168 hours of compression. I'm not sure what exactly she was wearing, but probably some sort of flat knit. And then her limb QL was a 68. So that was pre-debulking. And then I have numbers from pre-lymph node transplant. Do you want me to say those too?
No, I think that's good.
Okay.
Just so we have two comparative
Yeah.
points. Thanks.
Okay, so I'm going to show you a couple of series of MRs. This is the baseline study. This is before any surgeries. So again, the images on the left here are fluid sensitive, so things that are bright or correspond to edema. And you can see there's quite a decent amount of edema overlying the left hip. And you can see that there's a moderate amount of edema overlying the left thigh. And it extends all the way throughout the left calf. This is just above the ankles. This is a coronal image of a fat-sensitive sequence. So again, things that are bright are fat. And you can see I just sort of put this orientation here so you could appreciate the fact that there's a decent amount of, I would say moderate amount of fat that extending sort of throughout the thigh as well as the calf. So this is post-debulking now. This is now we're in 2018, and one of the things you see here is starting with the fat images. You can see there's actually less volume now of the lower extremity in comparison to the right. If you look at the fat here, for example, it's actually less than it was before, whereas on the prior study it was the opposite. If you look at the fluid sequences, what's interesting is that you can see there was fluid before overlying the left hip. That's actually not there anymore. That is largely resolved. And in fact, the edema, while is still there, has also looked better. And then finally, this last set of slides is from 2022 when she has had her lymph node transplant. And again, in the pelvis, again, not much edema there. And then the edema on the thigh has actually improved. The ankle and the calf is about stable, and if you look at the fat, again, there is no sort of no substantial change since the debulking. Oh, this is I don't know. This is difficult to show, but this is actually this is what the lymph node transplant looks like on MR. This blob here is actually an artifact that's caused by one of the surgical clips. But next to that is actually a vessel that's coursing through the lymph node transplant. It's actually very small. There's kind of a small focus of tissue right here, but that just showed us that it was still viable.
Okay, so I only have two sets of scintigraphic images. The first on the top is from 2021, and down on the bottom is 2022. I actually do have another earlier set of images, but I chose not to show that because when Drew first came and we first started imaging lymphatics, I guess the nice way to say it is we didn't know what we were doing. And there isn't a lot, if you look in the literature, just a variety of ways to do scintigraphic imaging. And what we chose to do was sort of what we'd kind of been perking along with for many years, when you scan a patient every 2-3 months or so. And then Drew came and he brought a lot of business, and so we kept doing that type of imaging, but it wasn't adequate, and we recognized right away. And also the camera we had at that time wasn't that great a camera, so we upgraded our camera, we upgraded our protocol, and one of my big regrets is that we didn't do this earlier, because we've got a whole slew of patients that we've imaged with the old technique, and you really can't compare them to the new technique. So to see changes over time, pre and post surgery, is tough to do. So if any of your groups want to start scintigraphic imaging, pick a good protocol. If you want to get our protocol, send me an email and I'll email you the protocol we have. And I think it's fairly decent. We've stabilized with it for a while, but in 2021, we see the right side looks okay. We didn't see lymph nodes on the early images, and we usually like to see them. So that suggests she may have a primary problem, and maybe it was exacerbated by something unknown that she did. But then at 2 hours, we see lots of lymph nodes there, so it's not too bad. But at 2 hours, we really only see dermal backflow around the ankle and partway up the foot, or up the lower leg. And this is the posterior view, and don't see any popliteal nodes or anything like this. A year later, She's got a little bit more flow on the right side. So there is just variability since we didn't do anything to the right side. But again, she's got some dermal backflow, might be going up a little bit more, I've been interested that we don't see a huge amount of difference as they evolve over time. What we'd like to see is and Drew showed some pictures this morning of tracer being taken up into these transplanted nodes. And while we do see it sometimes, it may take 3 years or more before we see it. And I think that may just reflect the fact that it takes a while for these lymphatic channels to grow out into the tissue and start picking up that tracer that we give. And many times Leah will show a viable graft on the MRI, and I don't see any lymph nodes there, but we don't give up at that point. We keep after them.
Great, and one thing we're not showing here are the ICG images. So with all of our patients, especially the ones that go to surgery, we do this and we follow up on their ICG as well. So usually now in the conference, I would just summarize. This is a 57-year-old female who had secondary lymphedema of the left lower extremity. Usually I have all my cheat sheets in front of me, so I'm doing this off what everyone said. She's about 4 or 5 years out from a debulking, a couple of years out from a transplant. We see an improvement in her volume. We see an improvement in her edema, not only on objective measures, but also on MRI. We still see dermal backflow. And if I recall, Kathy, we picked this case because we chose it for LV bypass. And Kathy's saying yes, because on her ICG, so if you notice, her edema now is mainly in the lower leg. Everything more proximal is better, not only from a fat and fluid perspective, but the lower leg still had residual edema. So she had an ICG which showed a linear channel. So we backed that up with a high frequency ultrasound, and we went ahead and we did an LV bypass in her, I think, recently. And we actually bypassed a 0.4 millimeter vein to a 0.85 millimeter, 0.4 millimeter lymphatic to a 0.85 millimeter vein, and had confirmation of flow in the OR. And this was one of the ones you imaged for us, Leo, with your high frequency ultrasound. And so now she'll come back for review. Of course, we'll be following her clinically. She'll come back for review 1 year post-op, and we'll do all the imaging again. Questions?
Any questions from the audience? Online? Our colleagues from Australia?
Yeah.
Have you started a weaning process with this patient at all?
A weaning process.
So,
Oh, sorry. Yes, I think I was looking back at all of her notes. I think so, because she got the debulking and was in the 2 layers, the waist high and thigh high. Now she's just in the 1 layer of the class 3 thigh high. So she was able to wean a little bit, yeah.
and as I remember, she preferred to go slower than I wanted to go in the weaning process. She barely felt comfortable with the compression. So she's much slower than we would normally see. She wanted to keep some of that compression on.
And then fun fact, she actually went back up to the class 3 forte after she was in the class 3.
Even though her numbers looked good, and I said, I think you can go with a little less compression, she said, I'm happy with this.
And another tidbit in a way is to speak to something Kevin was talking about, which is it takes years before we see these lymph nodes. And so when I started doing lymph node transplant, I used to take lymph nodes from the groin. And when you take lymph nodes from the groin, you can bring skin. And we've published on the fact that when you do that, you can actually see the lymph nodes within 3 months of surgery. And that's because skin is a lymphatic highway. So when you inject technetium in the foot, it'll go up to the skin of your transplant and go straight down to the lymph node. But what I had a competing interest here, which was, all obviously patient-centered, was when I was taking it from the groin, there was data coming out of Finland saying that you are causing lymphatic dysfunction, even if the patient doesn't have lymphedema. And so the only donor site that got us out of that predicament was the omentum. But the omentum doesn't give us skin. So with the omentum, you have to have more patients. So this is something we still talk about, not infrequently as a team within the surgical clinic, but we feel comfortable right now sticking to what we're doing, which is the omentum, because we are having these patients come back after multiple years. We are able to light up their lymph nodes and demonstrate that they're viable. Leo can tell us at 1 year the transplant's alive because we don't see any fat necrosis. If the lymph node was dead, we would see evidence of that on the MRI. So we've decided to stick to a procedure that minimizes ultimate risk to the patient, and just we want to be more patient in visualizing these on our imaging.
This is just a quick question. How long post-op do the lymph node, I'm just asking you. How, okay, oh, sorry, for the people at home, how long after surgery do patients that are traveling for surgery to Boston, how long do they need to stay in Boston after the lymph node transfer and the lymph node transfer and whatever, the anastomosis?
So good question. So we have a lot of patients that come from afar, and there's what I have to tell them, and then there's reality. It's hard for me to advise anybody to get on a plane and leave the city within 4 weeks of a major operation, just because we know after any significant operation, remember these lower extremity lymph node transplants, they're on the table about 8-9 hours, upper extremity 6 to 7 hours. So they're at higher risk of getting DVT, clot. So my general rule is, you got to stick here in town for about a month with us, but it doesn't mean that patients will always listen to us.
And at least after the lymph node transfer, we're waiting 3 weeks before they can restart compression again. And you really have to see them to say, yeah, this looks good. We're clear to go ahead and put compression over this. So they can't get out of town before 3 weeks.
Yeah. I mean, again, we emphasize to all of our patients, this is a process. This is not a one and done operation. This is not a cure. I mean, they hear this from every point of contact with our team. And so usually by the time they get to the surgical clinic, they get it. And if they don't, it's a big red flag for me. If at that point I'm not hearing that from the patient in a way.
Tegan.
Okay, this is a left field kind of question.
Go.
Has anyone ever thought of doing deceased donor transplants so that you can have skin?
It's not a complete left field kind of question. The issue with a deceased donor is you now have to immunosuppress a patient, and that just brings in a whole new layer of ethics, morals, and generally speaking, so this has come up, for example, with face transplant, right? Kidney transplant, liver transplant, people don't argue about that because that patient's gonna die if you don't do it, and then put them under immunosuppression. But with face transplant, it's been generally accepted the patient's going to lose about 10 years of their life being on an immunosuppressive agent. So that's something we haven't really ventured into with this field. And I would stick with autologous when there's other sites within a patient's body and avoid that can of worms.
We have another question from one of the virtual participants asking if it's the same of lymph node transfers. Is it the same true of axillary lymph nodes that are transferred to the groin? Would that be causing lymphatic dysfunction at the axilla?
Axillary lymph nodes transferred to the
To the
groin.
groin.
Yeah, so if you take a donor site, the lateral thoracic donor site, a supraclavicular donor site, all of those sites, you do run a risk of getting arm lymphedema. Yes, so the exact parallel runs at those sites. It's a reason. I used to only do TCA or transverse cervical or supraclavicular or lymph node flaps for lower extremity lymphedema, But again, I stopped doing that because there were reports in the literature of patients developing upper extremity lymphedema. So that's why we've gone to the Amentum and we've kind of stuck there.
Has there been any complications with the gastrointestinal system with using the Omentum?
Yeah, so we have, so we have one patient who developed a small hernia. I think it was 1.8 centimeters. She decided to go non-operative. So that's when we used to do it open. We don't do it open anymore. We do it laparoscopic. We had one significant complication, which was we had a bowel injury. That can kill somebody, just to be clear. But this was in a patient who had 5 prior foregut operations. So this was a high-risk operation. She knew it, we knew it. And we went through the donor site options and saying we could go somewhere else. You just have to accept the risk of donor site lymphedema. And joint decision-making, we decided still to go for these nodes because we knew these nodes were present. And when we went in, the nodes were present. When we removed them, there was a bowel injury, which was repaired at the time of the procedure right away, and there were no complications following that. But we've written about this, we put in the literature that we did this, we did have a bowel injury, so it is not something to be taken lightly. I also will say, it hasn't happened at our institution, but it could happen at our institution. I know there's 2 reports of pancreatitis. So these lymph nodes, the best lymph nodes are located as you get closer to the pancreas, along the stomach. And if you get too close to the pancreatic head, you can inflame the pancreas and you can also die from this. Pancreatitis is something very serious. And there have been 2 cases from what I've been told, but I don't think those cases were reported in the literature that I know of. They might have been, but both cases did fine, ultimately with ICU support. But so yes, you bring up a very good point that diving into one's abdomen with central structures is not something to take lightly. Even though I'm board certified in general surgery, I am a plastic surgeon, but I have 2 board certifications. I do that part of the procedure with somebody who does it 4 times a day. So they come into the OR with me, and they actually now do that procedure, that part of the procedure, all on their own, because they do it laparoscopically. When it was open, we did it jointly. Now they do it laparoscopically, and they basically hand me the lymph nodes. And then Leo takes them, images them, confirms where the lymph nodes are, and then I do the implant. But it's a very good point. And our patients are well-versed in all of this before they sign up.
We have one more question from Robbie. Comment?
Thanks. Just a question about the bypass in this patient. I love how systematic you are with your MDTs and that you report on some very standardized things all the way through. And I noticed one of those was the size of the lymphatic vessel and the size of the vein. So 2 parts to the question. Firstly, do you ascertain the size of those vessels from the high-frequency ultrasound? And secondly, do you notice that there's a correlation between the long-term patency of the anastomoses and the size of the vessel?
Sure, so we do use the high-frequency ultrasound to assess the vessel size directly. So we can actually look at the lymphatic channel itself. I'll measure a diameter off of that. I'll measure the diameter of the closest superficial vein when I mark the target spot for drill.
Yeah, and then the follow-up question was patency. Yeah, so we haven't used that yet to do that. And I will say there are some very, very bright people who might be listening in from Europe who've approached us with similar ideas. So I think one day we might be doing this. And we've had to actually, in a case where we had a little complication, you used it to prove patency. Where if you want to talk about that a little bit. Yeah. Yeah.
Yeah, we had a patient who developed basically a lymphocele. Basically, it was kind of like a outpouching that was contained with lymph, and we actually used a high-frequency ultrasound system to look at that and to assess whether or not the channel was connecting back, or whether or not it had involuted or shriveled up and it was gone. And so I was able to use the ultrasound system to basically track the vessel all the way to the anastomosis, confirm that it was actually there and as I was working. So that was, so yes, the short answer is that that system has the potential to do that. And we probably don't use it as much as we could.
Yeah, agreed. A lot of it comes down to resources and time. You know, this is a machine that we brought in 2021. I think it's brought a lot of objectivity to what we do, but it takes a lot of time to get, you know, bring a patient to the unit, perform the study. So that's all stuff we're constantly modifying our protocols to integrate these new technologies. But you're right. So that case demonstrated we could use the ultrasound to show A, it was open. In this case, we had a leak from the anastomosis, which was self-limited and resolved at 3 months.
Great discussion. Thank you.